co-chair. And this is my maiden voyage. As part of our series on end-of-life issues, we will focus on hospice care today. This meeting will also be on Zoom and recorded. In addition to Zinnia, Scott, and Shelley, Chris Dupree from Hospice of the East Bay is here to talk to us. Chris, I'm going to read you the bio. Chris has been the nurse liaison of East Bay Hospice for 15 years. He's a revisiting nurse at Bruns House, special needs nurse for 13 years. So I don't think there's anything else I need to say at this point. I'll sit back and learn about hospice.
Okay. Go ahead, Chris.
Thank you.
All right, good afternoon, everybody. My name is Chris Dupree, as she said. I'm also here with my partner, Michelle, who works out here, my partner, Kat. Oh, my bad, sorry. Can you guys hear me now? Okay. So I got a few hospice questions, and then if you guys have any for me that I don't cover, but I'm gonna go down that list on hospice. What are the main questions? And I was telling Scott that these are a lot of the common questions that I get. And like you heard, I've been doing this a long time. I'm out there in the middle of the night doing visits, and I also do this, okay? All right. How does hospice differ from palliative care and hospice care? So Hospice East Bay, let me just tell you a little bit. We're one of the oldest. We've been around since 1977. And we were started by volunteers and nurses. And we're right over here in Pleasant Hill. We have an office in Emeryville. But we're one of the few nonprofits that are left. So back in the 80s, Medicare, because Medicare Part A pays 100% of hospice, pretty much. Equipment, medications, all that stuff. But back in the 80s, Medicare monetized hospice. So now you have all these for-profit companies. So it makes us very unique that we're still a nonprofit. And what that means is any money that we make, we just put back into services for our patients. Good example of that, we're the only hospice in the Bay Area that actually has the Bruns House. We're the only ones that have a hospice house in Alamo. Bruns family, their son died in a car accident in the 60s, and they wanted to donate money to a hospice in his name. So, being a nonprofit, we took that money and we started the Bruns House. So that's a good example of us being a nonprofit. Okay. So the differences between palliative and hospice. Palliative is basically the level before you're like, hey, you know what? I still want to go to the hospital. I still want to see my primary care physician. I still maybe want to go get blood draws or have a CT. All those things you can still do under palliative care. Where hospice is more acute care, palliative is less acute care. So all those things you can still do. Medicare usually pays 80% of that for palliative care. So there's usually 20% like copay. Some insurances will pick up that 20%. And then some won't. And what that kind of looks like out of pocket, if you were to do it monthly and your insurance didn't pick that up, it's usually about between like $400 or $500 out of pocket if your primary insurance didn't cover it. Okay. We are unique in the way too, because we also have a certified palliative program as well as a hospice program. And why palliative is good when you're not ready for hospice, when you get on palliative, they kind of manage your care. You have a nurse going out maybe once or twice a month. You have maybe a nurse practitioner coming to see you once a month. You get provided with a phone number, like kind of if you're like with Kaiser or somebody, you know, there's a nursing triage line and you can call like, hey, I'm having this, my head's aching. And you can call in the middle of the night and there's a nurse on the other end to kind of help you through that, right? So we kind of have that in palliative and We do have that in palliative and hospice. For palliative though, that nursing hotline is Monday through Friday, business hours, like 9 to 5. Okay, it's not on the weekend, so it's less acute. Whereas hospice, the difference there between palliative and hospice, we basically become your new 911 when you get on hospice. You get a 24-hour phone number, and that's 24 hours, 7 days a week. I was just explaining to Suki over here before you guys all came in. We became friends. Say, for instance, you fell in the middle of the night. Instead of calling 911 to have them come and take care of you, you would call our 24-hour number, and they'd go, okay, what's going on? Oh, I fell. 3 o'clock in the morning, any time of day or night, and I do a lot of the night visits. So say, for instance, at 3 o'clock in the morning, you call us, and they go, Chris, go out to Piedmont Gardens, so-and-so had a fall. Pretty much, I have a nursing bag in my car, and I've been doing 15 years, pretty much 90% of the things I can take care of. If you fell and broke a bone, well, then I would send you to the hospital. You can go to the hospital for those kind of things. So more acute on hospice, than palliative care. You're still going and doing your normal things, seeing the doctors and you can still do all your regular, go see your neurologist, your oncologist, whoever you're seeing can still do that. Where on hospice, all that stops. Basically, I always tell people, you're ready for hospice when you're just like, hey, you know what? I'm done. I don't want to go over here to Summit, Sutter. I just want to be here. I want to be comfortable and taken care of by nurses here in my home, no matter what happens. I don't want scans. I don't want any of that. That's when you're ready for hospice. So those are the big differences. Does going into hospice care mean I'm going to die? Do people leave hospice care? No. One of the big things that happens, people don't know a lot. They're not knowledgeable a lot about hospice, which is fine. Okay.
Right.
But you guys, I commend you for coming out and getting information. It's always better to be prepared. And I see this very many times where they panic. I'm now in the hospital. I don't know, what to do. And they're panicked and they don't know. And we're scrambling to get everything because there's a number of steps to come on hospice. Number one being a hospice referral. So basically a doctor or somebody at the hospital or doctor at the hospital has to go, yes, this person is, I think, qualified for hospice. And then they send somebody like myself on. And that's what I do. I was just over at Sutter this morning evaluating and getting a patient admitted on the hospice. But to get the information in your hands and get prepared is tremendous, because then you're not going to be at the last minute and going, oh my gosh, here I am at the hospital. I don't know what to do. So hospice is good when you're like, I'm just ready. I'm done with the hospitals. I just want to be comfortable. Not just anybody can come on the hospice. That's what I do. Like I said, I do everything, but I go and I evaluate. So I was telling Suki, a good example of this is sometimes there's not a certain disease that's that's making you decline. There's a thing called degenerative disease of the nervous system. Basically, I'll just say I'm 95 years old and my body's just not working like it. I'm not eating it. I'm sleeping 20 hours a day. All of a sudden, I was walking with a walker 2 weeks ago. Now I'm completely bedbound. These are all the things we start looking at. And there is a thing called degenerative disease of the nervous system when there is no specific disease. And you can come on the hospice for that. And I would go out and I evaluate you. I ask you all these questions. I see how you're doing. And then I make the determination if you're hospice eligible. It takes 2 doctors to come on to hospice, CTI doctors. And that stands for Certification of Terminal Illness. And they usually go 1 to 6 months. And people kind of freak out when they hear that. They're like, 6 months? I think I got longer. That's just how Medicare Part A, because they're paying for it, remember, 100%. That's just how they do their cert periods. So you say you get to the end of that 6 months, and then Medicare, our doctor, the hospice doctor, because that's the second doctor, first one hospital or your primary care physician, second one our hospice doctor. So after that first cert period of those 2 doctors, then you get to the end of that 6 month period. We're always evaluating. We're always, because people do come off of hospice. That is a thing. We call it graduating off of hospice. Sometimes people just do better when they get on hospice. So that second doctor just recertifies and there are 3-month cert periods thereafter. And I've seen people go on a lot of cert periods on hospice. Okay. So you're not necessarily meaning you're dying, right? You know, but like I said, you can come on to hospice and the care can start in your home. And we would have to evaluate because, you know, not just anybody can come on. So we look at all that criteria, like, well, what's been going on in the last 6 months? You know, are you sleeping more? Are you eating? You know, are you now incontinent? You can't make it to the bathroom. These are all the kind of things that signal that maybe it's time for hospice. Okay. People do, so they do graduate off hospice. We're a nonprofit. I always tell people we're not making money off of you. Sometimes when people, I'll use dementia for instance, sometimes we bring people on with dementia or Alzheimer's. They come on to hospice and statistics show that when people come on to hospice, they live longer, they do better. That's actually a national statistic. You know why that is? That's because now you have nurses and doctors taking care of you weekly. Like we're coming to you, we're your new 911, you have a regular RN case manager coming in to see you every week. You have a home health aide, which, you know, they can come in and they help you with like showers or bathing. But people tend to go longer on hospice, okay? And we've seen this many times where people are doing better, all of a sudden you weren't eating, oh, now you're eating. You weren't walking, you were bedbound, all of a sudden you're walking with your walker, your cane now. These are things we look for and we assess. So, and then guess what? Our doctors are evaluating, you know, those cert periods, or our nurses are always constantly assessing and evaluating. And then we would have to bounce you off of hospice. Okay? So thank you. Next thing is, what are the reasons someone might be admitted to hospice? Who is involved in the decision-making process? Well, those 2 doctors, those CTI doctors. What happens a lot, I'll use that patient. I'm not giving up any HIPAA violations because I'm not gonna say any names, but I had a patient this morning. I was at Sutter at 8 o'clock this morning. Doctor, he was admitted into the hospital and doctor's like, nothing more we can do. It's time for hospice. I went in, evaluated, we got him transferred to our Bruns house. Okay. So usually you're either hearing from a primary care physician, a doctor, maybe there's a social worker you're working with and they're seeing, maybe you're on palliative. Nice thing about palliative, when you come on to palliative, they really kind of coach you and kind of go, now it's time for hospice. And it's kind of like a nice transition because again, not a lot of people know when that time is going to be. So that's so those 2 doctors or your primary care physician, our doctor, myself, I'm allowed to, you know, to determine if somebody is appropriate for hospice. So it's a whole team effort that makes that decision. Okay. What does hospice care include and who will come and how often? So hospice, when you come on to hospice, you have your routine level of care. Basically, you get assigned, just like when you go in the hospital, one of the steps is an admission nurse would come out here. I just had somebody out here a few weeks ago, and our admission nurse came here, admitted them onto hospice. They're doing the vital signs, or looking at the medications. We become, because you are in a community, it's really nice because there's nurses here, there's social workers here, you know, like Scott's here. We become a team with your team that's already here. And there's constant communication. But you would have an RN case manager assigned to you, and then they come out every week. If you're doing great and you're still not declining and you're on hospice, that visit may be once a week, but it's at least once a week. As things decline, those visits pick up to the point where when somebody's transitioning at the end of life, it becomes every day. All right, you get a home health aide assigned to you. So some of you guys may already have, you know, hired caregivers besides the staff here helping you, especially on an assisted living side where you're a resident. Some people just need that extra help, you know, maybe, you know, get your food or helping you take a shower or something. But the home health aides come in and then they can help with showering or bathing. They'll change that, the sheets on the bed. So they do that. You get a social worker assigned to you. They're gonna be making visits to you and seeing how things are going. Nice thing about us, we have over 250 volunteers. Sometimes nice thing for you guys, you're in a community. You probably have lots of friends. But some people are at home and they're by themselves, or maybe it's just a husband and wife and they don't have anybody, but we have over 250 volunteers that can come and spend time with you. They can't do care, like medical care like me, but they can help with like a meal, they can keep you company. You get assigned a chaplain if you're religious and you want somebody to come. I know you have a chaplain here, but if you wanted extra, a chaplain would come out and pray whatever your religion is and, pray with you or talk religion with you, okay? We have music therapists on your team, so they'll come and play acoustic guitar. We have somebody who plays actually the harp, it's beautiful. We have pet therapy, that's my therapy, I love animals. So somebody, if you love dogs or cats, somebody can bring a dog or a cat out to you and just make a visit. So that's the whole team that gets put in place when you come onto hospice. And like I said, those visits, and I always tell people, like, well, do I have to have a social work? Believe it or not, sometimes people go, no, I don't want, I'm just the nurse. I don't want a social work. So guess what? You are in charge of your care. We are here to help you and support you and take care of you. But in the end, you are in charge. Nobody's going to force you to do anything. Okay? But so that's the team that gets put in place. What changes can I expect when I go into hospice care? Well, so you guys are here. The changes would be that you would now be having regular nursing visits every week. You would have somebody communicating with you, like I said, a social worker. You would have all those services put in place. You would have that 24-hour phone number. Like I said, we keep you out of the hospital. We manage all those symptoms, and it could be anything from nausea and vomiting, to pain, to agitation, whatever the symptom is. The whole point of hospice is comfort, making sure you never suffer with any of those things. So we're always managing the care you get when we come out every week. When we start taking, we do your vital signs. Our hospice pharmacy takes over, so we start doing your refills for you because we're looking at the medications. We'd be talking with your med tech or whoever the one is here that's in charge of your medications. You guys probably are, I don't know if a med tech takes care of your medications, but we start working with everybody here. So we start ordering our doctors start writing your refills. We're doing your vital signs every week. If you have any skin issues, a wound or something, we start taking care of that. We manage everything. If you're not having a bowel movement every 3 days, guess what? We're asking, like, when was your last bowel movement? And if I'm the nurse and you haven't had a bowel movement in 3 days and I'm assessing you, any abdominal pain, any nausea and vomiting, I'm asking you all those good questions and stuff. Because what happens when you come on to hospice, we deliver an emergency kit of medications. In there's like morphine, lorazepam, haloperidol, Dulcolax suppositories for constipation. We start managing everything. We're ordering your medication because we never want you to be without anything. And they get delivered directly here. And you may have pharmacies doing that already here, but it's really a big deal, especially for people who are still in, like a resident home or something, and they're by themselves and they can't make it through the pharmacy. It's a big deal to have your meds delivered right, to you, and you not having to worry to go to CVS or somewhere to pick those meds up. Okay. So those would be the big changes that you would see. You'd get really just another level of care that's happening every week. And we're taking care of you. Just somebody added to your support team. What are the advantages of hospice care? Are there reasons I still might be sent to the hospital even though I am on hospice care? Well, the advantages are the 24-hour phone number. And I don't care if you're like, hey, my breathing seems different. I always tell people, you call that 24-hour number and you're like, hey, I would really appreciate it if a nurse, and it doesn't matter what time or day or night, we come out and I would come in and assess you and take care of you. That is a big deal, knowing that you have that, you're not having to wait. The other thing, 15 years, I do a lot of the night visits. When I go out in the middle of the night, guess what? There is a doctor on 24 hours a day, 7 days a week. I have never, my 15 years, not had a doctor pick up. They always pick up because they are on call. And I can get a verbal order over the phone for a medication change. That is really special. You're not having to go, oh God, do I have to call 911 and go to the ER? And you know, I'm sure everybody's been in the ER before. I've been in the ER. And then you're sitting in the ER for hours and we're taking care of you. And like I said, 90% of the things we manage. What would you be sent to the hospital for? Because that all stopped. Well, I was telling Suki earlier, say you fell and you called me at 3 o'clock in the morning and I come out to make a visit. I'm assessing you, I'm looking at, and I suspect you have a broken bone. I don't want you to suffer. I would go, is it okay if I send you to the hospital? And then you can go to the hospital for that. And then they would do a scan and take care of that. Or a UTI, urinary tract infection. We don't do, when you come out of hospice, you can't do IV antibiotics, but our doctor, we would take a urinalysis and we would write a prescription for oral antibiotics. Because again, we don't want you suffering with anything. We really manage that. And remember what I said, statistics show that people go longer on hospice because that's the level of care, just another level of care. You come on to hospice, say you have Blue Shield, your insurance just comes down here. And hospice, Medicare takes over and starts paying for everything. And that's then just a higher level of care. And we're coming to you now. Okay. Let's see, how does hospice coordinate with my primary physician and nursing or wellness at the community? Well, we're always in community. Remember, we become a whole team. Communication is huge. Whether it's a med change, whether it's a condition change, a wound, new wound that came up. We're always communicating with the nurses here, with the doctors here. So we become like one unit, we become a team with whoever's here. A lot of assisted living, a lot of nursing facilities, boarding cares. There's all kinds of different places people live out there. You'll find that a lot of these people that work in these communities love it because they're getting the added help. They like it that they know that they can call that 24-hour phone number, that 911's not coming in here with an ambulance. You know, they know that we're here to support. Or, you know, sometimes maybe your nurse visited on a Monday and it's Wednesday. Usually we do those real fills, but you know, maybe, you know, the med tech calls and says, hey, you know what, can we use this, you know, can we get this? And so there's always that communication. We're always, and I do those visits too, because guess what? You have an RN case manager, but they take vacations, they get sick. We always want those visits to happen. So when I do those visits, I'm usually calling ahead and going, hey, my name's Chris. Your nurse is out today. Is it okay if I make a visit this morning at 11 a.m.? You're like, yeah, sure, come on. And then I do everything. I'm checking with the med tech. I'm talking to anybody in the community, communicating with people here because we want to keep everybody, you know, in the loop. Okay, so that's how that works. Who pays for hospice care? Well, like I said, Medicare pays for that little box on your pay stub that says Medicare tax. Guess what? We've all been paying in that since we've been working. And when you get to this age, guess what? We're all gonna need hospice one day. Me, everybody. And that's the benefit we get. Medicare Part A pays for it, 100%. That includes any equipment, like say you need a hospital bed, say you don't have a walker and you are walking, okay, now you need a walker. All that stuff's covered and we can get it same day. Commode, whatever it is, we can pretty much get oxygen. Sometimes people start having shortness of breath and they need oxygen. We would order you oxygen and get you started on that. So the majority of the medication, all the hospice medications are covered. Anything associated with your diagnosis is covered. Sometimes a medication pops up that's not covered. For instance, cholesterol medications, Medicare will not pay for. usually when we get to the point of hospice, the doctors really review everything. And they're like, really, you're 98 years old, is cholesterol really gonna be an issue? And we make suggestions. We never take away anything without your consent. So say you did have cholesterol medication, we go, hey, are you okay if we stop this? And also we want to lessen what we call pill burden, because taking a lot of medications can have side effects. So, and they can contradict each other. There's all kinds of different things, but we're always, again, because you're getting that level of care, we're always managing that. We're always looking out for those things. But if you said, hey, I love my cholesterol medication, I don't want to stop that, you would just keep paying out of pocket or through your secondary insurance. But pretty much everything is covered. If you're incontinent, all those supplies, diapers, wipes, gloves, skin barrier cream, if you have a wound, all those supplies are covered, all those wound care supplies are covered. So pretty much everything that's Medicare Part A is paying for everything. So really nothing out of pocket. And that's it. Any questions? I know it's a lot of information. Yes.
I have Kaiser coverage. Does the Hospice of the East Bay work with Kaiser?
We get a lot of it. So hospice, so Kaiser does have their own hospice, but guess what? They only take so many. And you have the right to pick whatever hospice you want. That is a law. So Kaiser can't go, no, you're a Kaiser patient, you have to have Kaiser hospice. No. They have to, and guess what? We get a lot of their patients. And I think they have a really good hospice, by the way. I'm not just being, but we get a lot of their overflow. So Oakland Kaiser, I was just at Walnut Creek Kaiser. So we get a lot. And to get the hospice ball rolling, you have to get a hospice referral. Remember I said that? That's kind of the very first step. Kaiser has what they call a hospice hub. So a lot of times I can help. Like I can call somebody's primary care physician. Sometimes when nurses are calling, they have a special line and they'll go, oh yes, I'll get that to you right away. Sometimes when a patient calls, they can drag their feet. And guess what? They do get busy. Kaiser is very different. They want everything to go, the patient is the only one that can call Kaiser to request that referral and get that process started. But yes, we get a lot of patients through Kaiser.
Thank you.
If you raise your hand, we'll come around with a microphone.
Chris, go ahead and repeat their question.
Oh, okay, yes.
Does the recipient need to acknowledge that he is in hospice care? The situation where my dad signed on, the next day he said, I'm not dying. And they had to do it 3 times.
So does the recipient have to acknowledge that they need hospice care? So what happens, especially with dementia or, when that capacity starts declining, if you are like what we call the durable power of attorney, the DPOA, you get to make medical decisions, you get to do all in the name of your father, then you could sign. And so there is a thing, and we say, when we sign those consents, we say lacks capacity. And you are the one, in charge of medical decisions. Because guess what? That does happen, especially with dementia, Alzheimer's. And that's where they're protected because they can't make those decisions for themselves.
Lacking a diagnosis of dementia or incapacity.
Well, if they are sound mind, then we cannot just bring them on the hospice. So you may go, hey, Dad, you really need hospice. And he may go, sorry, son, you can go take a flying, yeah, if he has capacity, we have to look at that. You can't just override him. So. Yeah.
Oh, you want me to use that?
Hi, Chris. Several times you referred to something called Bruns House, and I'm curious what that is.
Well, thank you. I didn't know how long I had, so I didn't want to take too much of your time. Remember so Bronze House was started in 2004. We just had the 20th anniversary. And basically, we want to always keep you out of the hospital.
Yeah.
So say you were here and all of a sudden, because we don't know how that journey is going to go. It may be a peaceful journey. But every once in a while, something comes up, whether it's maybe unmanageable pain or maybe intractable nausea and vomiting. There is a thing called terminal agitation that some people get at the end of life. We want to always manage that. The goal of care is always to keep you in your home. But those times that it comes up, and say, for instance, you're taking oral pain medications for pain, and we've been dealing with it for 8 hours, and we're talking to your team here, you know, and they're like, oh, for the last 8 hours that we've done these medication changes, we've tried this, you know. Sometimes it's just getting something dialed in, you know, whether it's a frequency change or a dosage change. We're always, you know, trying to manage things where you're at, because that is always the goal of care. But it does happen, and to keep you out of the hospital makes us very unique, because we're the only hospice that has a Bruns that has a hospice house in Alamo. It's a 6-bedroom house, all private bedrooms. There are 2 nurses usually on 24 hours a day, 7 days a week. There's a home health aide on there 7 days a week, 24 hours a day. There's a social worker, doctor assigned there. So say we've been sitting here for the last 8 hours and your pain out of control. If a bed was available, we would go, and I'm sorry, Susanna, we'd go, Susanna, we think you need IV medications. Are you okay if we transport you over to the Bruns house? And you're like, yes, I'm out of my mind on an 8 out of 10 pain, please. That's what's nice at the Bruns house, because those nurses there, we do IVs, we do pain pumps, sometimes people need gastric pumps. We have all that equipment there. We can manage that there. And you can, Medicare Part A will pay for that if it's for symptom management. What the goal of care is always is to get that symptom managed. They wean you off the IVs, get you back on your oral medications, and sometimes that's all it takes. And then we would transport you back here, okay? But you can only go there for symptom management. Some people end up going there, and let me tell you, it's a beautiful 6-bedroom home, all private bedrooms. There's usually when somebody's in that situation, it's gotten pretty serious, okay? There's pull-out beds for families, because usually a family member wants to stay there with their loved ones in the room. So there's pull-out beds in the rooms with the patients that they can stay. There's a family shower, bathroom, because people usually they're staying there with their loved one. People cook in the kitchen, people barbecue. There's a barbecue in the backyard. It is really meant to be a home environment. Only there's no signs on it except when you walk up to the front door. It's on Miranda Avenue in Alamo. If you know Alamo, it's a gorgeous neighborhood. Between Livorno and Stone Valley, you walk up to the front door, there's just a little bronze plaque that says Bruns House. Otherwise, there's no signs on it. It's very private. Most of the bedrooms have French doors on them. People, sometimes we wheel the hospital beds when they're bed bound. People want to be outside. We'll wheel the beds outside into the backyard. There's no restriction on visitation hours. People, you know, will come in. I was a nurse 7 years on the night shift. People will come like, hey, I'm working all day, and they'll show up at 2 in. There's no restriction. You walk in, there's just a little nurse's station inside, just to the right on the front door. But we accommodate a lot there because we want people to feel at home, and it really does. People get there, and sometimes people will go, wait a minute, I know I'm under control, but I think I want to stay here. It's $1,500 a day to private pay, but some people who have the means will private pay there, but it's that nice. And if you go to our website, there's a little QR code, you can see they do like a little virtual tour. But I mean, we try to accommodate people have gotten married there, patients. We had one patient, her mother was dying there and she didn't have much longer, and the daughter wanted her mom to see her marriage, so we put her in a wheelchair, got her in the backyard, and her daughter got married in the backyard. She got to see that. Somebody was a horse person. They brought a horse. They opened up the French doors so she could be with her horse. That's the kind of environment it is. It's a very special. It's crazy to me that we're the only ones have that. There's a children's one called George Mark House in San Leandro. Besides us in George Mark House for children, it's a shame. It's always nice when you come on the Hospice East Bay, and that's a really big, I think we're a very special hospice. I haven't worked here for 15 years for just, no reason. One thing that really makes us special though is that Bruns house, because we never know again what that journey is gonna be. And to have that in our back pocket and to be able to offer that to you is tremendous. And guess what? We get a lot of transfers from other hospice companies, and I just was on the phone with a daughter a couple of days ago because she's like, oh, well, what if so we do get transfers, and one of the reasons is because of the Bruns house. They like the fact that they know that we have that in our back pocket.
I have a question. You know, if we're in hospice and we're living here at Piedmont Gardens, whatever level we are, and a situation occurs, I'm not certain, do we call the nurse here? Or do we call you in case we need help?
Okay. Oh.
Chris, this is in.
Hello, everyone. So the question is, if you are in the residential living, who do you call if you need hospice nurse, hospice care? So the first thing you need to do is connect with the wellness nurse. Because the wellness nurse, which is Zenaida and Ruby, or you can connect with me, then we can coordinate that with your doctor. So we get an order, and then you have a choice which hospice. Even though, let's say you're Kaiser, you still have a choice, so you should connect.
Suppose we're already in hospice.
So
Suppose we're
connect,
already in hospice. Do we call you or we call him?
so there's a, for emergency, and if you don't have the nurses, then you press your pendant. Then the nurse will come, assess you, then they will be the one calling your hospice agency, yeah.
Okay,
And then the nurse will come and check you.
okay.
Yes, so just press your pendant.
So we call you first, no matter.
Or you press your pendant.
Okay.
Although you still have the right to call the hospice agency directly. So it doesn't stop you from calling your nurse directly, okay? So if you're home, because there's a folder that's left in your room, you can always call your nurse,
Hospice.
the hospice nurse, but it will be easier, you press your pendant, we come in, and then we can support you by helping you connecting with the hospital.
Okay, so
I have a scenario of being perhaps in independent care on hospice. And I need help getting dressed in the morning and getting undressed at night. Is that expense covered under the hospice program?
So no, hospice, we're here to support you, but we don't take the place of caregivers. So if you need that support, then you either have to check in with your community and see. I know we just had somebody here who had a personal caregiver that they had hired. Because they did need all that extra help. Okay, so yeah, you would have to pay out of pocket. And like I have like a brochure, we really vet our agencies, but if that came up, I'm sure you guys know too, you probably have that.
So you have the choice in the residential living. If you need support, then that will be out of pocket. But let's say you don't want that, then you always have a choice to go to skilled nursing because they have the help there. So I know sometimes you're gonna need like maybe 24-hour help, and that will be very costly. So you have that choice to either hire the private duty and you stay in your apartment, or we can assist you by moving you to skilled nursing. And that way you don't need to have that 24-hour because they have the built-in help.
So there is no difference between being on hospice or not on hospice for that kind of care. Is that correct?
That will be out of.
Right. And Cynthia just clarified that they're paying in skilled nursing, that hospice is, so they're still paying for skilled nursing or.
Right, so when you move to skilled nursing, then that's still gonna be additional cost for the, like a custodial care. But the hospice care itself will be covered by your insurance.
I have a question. Is this on?
Just talk right into the top of it.
Okay. let's say you need one house, but it's all filled up. What happens?
Usually Bruns House averages about 4 beds full. So usually, I would say 90% of the time, there's always a bed. But there have been those times, because we get a lot of patients from the hospitals, when Bruns has been full, and then we put you on a wait list. And not to be, usually when people get into the Bruns House, it's a pretty serious situation. So usually people pass at the Bruns House, so usually there is a bed available, and that's how it works. But very rarely that we have to put somebody on the wait list, but it has happened, so that's a good question.
I know the answer.
Were I on,
Just a second, Jay. Go ahead, Karen.
I just wanted to question whether or not you have to have a roommate or not have a roommate, or can you not have a roommate
A roommate where?
for hospice?
Well, it depends on your situation here, that's however you're living. If you have a roommate here, we would just, taking care of you and going in and saying hi to your roommate, doing all your care. So, yeah.
Go ahead, Jay.
got one who's in independent living here, who needs symptomatic treatment requiring IV, go to skilled nursing instead of a hospital?
Go ahead, Cindy. Repeat the question.
So if you're gonna need like IV fluids, if you are living in the residential, then yes, you need to move to skilled nursing. In order to do that, we need to get doctor's order. So hospice will give us an order to give it to skilled nursing so that you can admit someone there.
So that's really the only way to go to skilled nursing without having been hospitalized for 3 days.
So you can't come on the hospice and do IV fluids. You can't, all that has to stop when you make the determination to come on the hospice. So you would not be on hospice if you went to the skilled nursing and you decided you wanted, that's good. And this is harsh as it sounds, that's considered life-sustaining treatment. If you got to that point where you needed IV fluids, Medicare considers that life-sustaining treatment.
I was talking about unmanaged symptoms.
Oh, so, yeah, unmanaged symptoms, say you were on our hospice, then we would offer you Bruns House and we would get you on IV meds there, because we start IVs there, we do pain pumps there. I don't know, do you do that in skilled?
So IV pain medication, probably. We haven't really had any experience with residents that needs an IV pain medication. Usually, there's different medication, stronger medication than like in liquid form that we provide for the resident, because what we're trying to do is prevent you from moving from one place to another. Because your goal is to die peacefully and comfortably in your home, right? So we try to manage it with the oral medications. There are some hospice agency that when there's like an acute illness or like behavior, let's say resident is very restless and we're not able to manage it. There are some agencies that will provide the nursing care, like the licensed nurse, and they will come here and spend, whether that's 24-hour, and that's also like observation for the behaviors and all that, so that they can manage what is the right treatment for you or manage pain management that you need to do that we can offer. So they will send the licensed nurse here and stay with you in your apartment and observe for 24 hours to up to 3 days.
Yeah, that's called continuous care. I didn't go into all, because I don't know how much time we have, because usually when I go in and explain hospice, I go over all the levels of care. So Bruns House is like that, but the first thing we would offer you is our continuous care. So basically, all that is, we would always offer Bruns House first, because, maybe you need an IV or something, and, things can get really managed. But you're like, no, we want you to stay here at your home, then we'd go, are you okay with continuous care? I call the doctor, I get a doctor order, and basically what I do is I have a laptop in my car, and I come and sit with you in your apartment for an 8-hour shift. Last one I had like 5 months ago, was in a community in Walnut Creek, and it was for severe shortness of breath. And I went in with my laptop, I'm on the phone with the doctor every couple of hours, trying to get it managed. And like I said, sometimes it's just like what Zinnia said, getting the meds dialed in. Sometimes it may be stronger dosage, maybe it's more often frequency. But I had that patient manage after 4 hours, but we stay the full 8-hour shift. I stayed there for the extra 4, even though that patient was comfortable after 4 hours. And then I'm updating the doctor. Sometimes, like what Zinnia said, if it continues past 8 hours, guess what? If I'm here taking care of you, then another nurse relieves me at the end of that 8 hours and we start another. We never cut out or take off in the middle of a shift. We always stay the full 8 hours. So whether it's 16 hours, 24 hours to get it managed. Okay. So that's kind of how that works.
Other questions? First one.
My sister was under hospice care just for the last few days of her life and was given IV morphine. And when she was very uncomfortable, but still here. And I was wondering what happens. You say you don't give IV medication?
I shouldn't say that's a never. Sometimes people, will, IVs, because it's the frequency, how often it's getting. There's, you gotta keep that very clean and sterile, the port. So a lot of things can happen when you're doing IVs. We always want to offer you and especially if you're getting to that point, we never want to move somebody that's that fragile. And that even happens in the hospital where they're like, hey, they need hospice. And we look at them and they're like, they can't be moved in an ambulance because they'll pass. We have made exceptions where we've done IVs in the home and stuff, but they have to really, because of the frequency, how you're giving it, and who's there with you. So usually that's not a common thing, but there have been exceptions.
Oh, I have a question. There's one first, and then you.
Yeah.
Oh, we did, okay.
Okay.
I wanted to know, have you ever given IV to independent living?
Oh, sorry. So there's regulation in the residential and we are not allowed to give IV fluids or IV in the residential, nor assisted living or memory support.
So only in skilled
In skilled
nursing.
nursing, yes. So that's why when you have hospice care here, we always go with the oral. And there are, morphine has an oral liquid form, so we just provide that, whether that's every 8 hours to every 6 hours to every hour or every 15 minutes. That's how usually, the doctor orders when you are at home.
Yeah, usually I'd say a majority of the time we can manage those symptoms, like what Xenia said. Like she said, we do have, hydromorphone, Dilaudid, we have methadone, we have morphine, we basically have an arsenal to take care of those things. Most of the time, that's basically what it is. So most of the time, we pretty much can manage it. And like Xenia said, we're working with this team here. It's really nice because they know they can count on us. We know we can count on them that if you called and their nurse went in and you're like, hey, this is going on, they know they call us and we come out any time of day or night. But a lot of times we can manage that. The nice thing about the Bruns house, it's for those exceptions and those do pop up. Because like I said, we don't know what the journey is going to be. We don't know. It just may be a nice peaceful journey, but we don't know how any of us are gonna go on that journey, so.
Another Karina?
Hi, I've had extreme pain for quite some time, and sometimes it's 10 plus. And I'm on Belbuca, which is more expensive than the other medications you mentioned. But that's what works for me. It's the only thing that can calm my pain, and they can increase the dosage. Can I still stay on Belbuca and my pain management doctor, who I've had for more than 10 years, can up the dosage if needed?
I'm not sure about that particular medication, but I could find out and it's called Balbuca.
Yeah, BELBUCA. Who's that?
Okay, I've never heard of that one, but what I can do is, because there's people that are on ketamine, there's all kinds of different pain management meds out there. I can find out for you, and I would be happy to relay that to Scott. And that's a nice thing. I have access to doctors that can let me know. So I can't give you, I'd have to find that out. Nice thing about hospice though, we are the experts at managing that kind of stuff, the pain. And we get that all the time where people have uncontrollable agitation or uncontrollable pain or something. And usually we can get them pretty dialed in pretty quick, and it's just that level of care, but that's what we're the experts at.
Okay, good.
Other,
Hi, this is the first I'm hearing about hospice, and I'm missing a whole bunch of pieces in between. So I would want to know, for example, if one of us had a severe stroke in the middle of the night or in the middle of the day, what happens in terms of hospice? When people, let's say it's a cerebral stroke, right? Then the timing for getting on hospice, how does that work?
So she's asking if a patient or a resident here has a stroke, what the timing is. Well, if you're on hospice and you have a stroke, which that has happened. No, I know you're not on hospice.
Yeah.
But I'm saying,
if that person still was not.
yeah, then you would have to be sent to the hospital and get treated. Okay, if you were on hospice and you had a stroke, then you are kept comfortable, because remember, we're no longer going to the hospital. But if you're not on hospice care, I would assume they'd call 911 and they'd get you over to either Kaiser or Sutter over here.
And then if you continue to live.
Right, yeah, so.
Yes.
And that's where like advanced directives, that's where having your wishes made known and somebody who is a durable power of attorney would be able then to know your wishes, that you would want to be on hospice if that was appropriate for you, and then they would have the ability to get you into the hospice program. Say again?
It would take 3 days.
Oh, I do.
So say you had a stroke, and this happens a lot, and you go to the hospital and they're like, you're minimally responsive, but you're still, your respiratory rate, all your vitals are good. And you have a durable power of attorney to make medical decisions for you, which I suggest everybody should have that in place, because that's very important. That person would go, hey, and usually the hospitals will call us if it's Hospice East Bay, and they go, hey, this patient, can you come evaluate? Well, it's a no-brainer. You would be able to come on the hospice, okay? And we would bring you on, and then we would take care of you wherever, if you were brought back here or a skilled, nursing, wherever, we would start hospice there and take care of you, make sure you were comfortable during that time. So that's kind of like what Scott says, that's how it works. That happens all the time. Like I said, I commend you guys for getting hospice, information. And guess what, guys? I kind of did a quick overview because, of time. This is what I do. If I left my cards, my number, Scott has my card. Guess what? We do free talks. I come out, I was just out at a patient in Berkeley. Sometimes people just want the full information, and I can come and sit with you. Usually it's about an hour, and I run down all the services and all the details and answer all your questions for you. So feel free. I'm leaving my number, my card, and I will come right here to you, and I can just talk to you about hospice. So that is a service that we do. That's my partner Kat over there. So that's what she does. So any of us can come, and we're teammates. So that's what you call us and we can come out and do that for you. Okay? Do that all the time, all week.
Probably have time for maybe one more question or so.
Can I
Comment.
just-
Did you have?
Can
Yeah.
we check in with anybody on Zoom who might want to ask? I didn't get any questions in the chat. I don't, maybe there's one. Oh, isn't there still a requirement for a terminal diagnosis within 6 months is one of the questions coming forward.
Yes, so if you heard me before, it takes 2 doctors to come on the hospice. Those are called CTI doctors, certification of terminal illness of 1 to 6 months. So whoever your primary care physician would be, you would call them up, or they would, sometimes they just say, hey, I'm sending this out. I think you're ready for hospice. There's nothing much more we can do. You should be comfortable at home. So that process would be, and you know what, sometimes people aren't ready for hospice when that doctor from a primary care physician or the doctor from the hospital sends the referral, but they still send the referral out upon your request. And then I come out and I evaluate, and then if I don't think you're appropriate, then I say, no, you're not quite appropriate. If I think you're on the fence, then I call our CTI doctor, the second doctor, and then we talk it over and they go, yes, bring on that patient, bring them on to hospice, and that's how the ball gets rolling. But first getting that hospice referral, a lot of people just say, hey, and like I said, some people get disappointed because they know the level of care they get with hospice, which is kind of weird and crazy, but people know what hospice does. And I'll say, sorry, you're not appropriate. And they go, oh, really? They get disappointed and it's because they know the level of care and stuff. So, yeah.
Shelley had a.
Hey, thank you so much, Chris. I just wanted to clarify one thing, which is that hospice chaplains, and the ones that I know, and maybe they're different than the ones you know, but hospice chaplains are available for you if you have a particular spiritual or religious stream, but they're also, like me, they're also available to you just for support. So if you are in hospice and you're asked to get a hospice chaplain, you can clarify what you need. And they might just be a really great support for you to talk about dying and what that process is, about being ill. They might also want to help support your family. So just because you might not be a religious or spiritual person, don't say no to the chaplain, because the chaplain can be a big support on the hospice program.
Also, I just want to add, like, let's say hospice refused you or denied you for the hospice care. Don't feel bad, because we can always call them after a couple months. If there's any change of condition, we can always call them and they'll have them assess again and see whether you're appropriate or not.
Yes, and I do that too. So say I came out and gave you information, and I said, oh, you're not ready for hospice. Then I go, hey, is it okay if I follow up with you in a month just to see how you're doing? That's just kind of one of the services that we do. And then we just check in with you. And you're like, oh, no, I'm still eating, Chris. No, everything's still fine. Nothing's changed. And so I have a whole calendar that I'm constantly following up with people. And people like that because then you don't have to jump through any hoops. Okay. And guess what? My other partner back here, Michelle, she's always around in this community. If somebody wanted like information about hospice, or she's my partner also, she can help with that. Okay. But yeah, that's kind of how it works. And, everybody here is good, and all the facilities and the, assisted living are great about, like, we all start getting in the loop and we start communicating about that kind of stuff.
Great. Thank you all for coming out today, and I want to say a special thank you. We actually had a different speaker that was supposed to come that I didn't find out till Friday that this person was no longer with the company that they were with before. And then I went, wait, I know Chris. So I actually reached out to Chris kind of last minute, and he just jumped in here today to present for us. So I'm so excited. Thank you all for coming. Oh, wait a second. Linda is not done with her job yet. Hold on 1 second.
Don't go yet.
Don't go yet.
Next Wednesday,
Yeah.
July 31st, from 3 to 4:30. Hear speakers from the End of Life Choices, California. Information will include voluntarily stopping eating and drinking, the use of dementia directives, and advanced health directives. So that program has been organized by Dorothy Prager. And thank you all for coming.